I'm going to review the glaucoma section. My presentation sticks pretty closely to the BCSC series, so this is really geared as an OCAP written board review. I think there's still information for people who are doing the MOC process, but I did the MOC and it's not, they don't ask as detailed of, in minutia of facts like the OCAP does. And I don't have any financial disclosures. I forgot to put in a slide, although I am on the BCSC program committee for this book, for the glaucoma section. Okay, and another note about this lecture, I have not been very consistent in highlighting the highly testable facts that the OCAP and the written boards tend to like. Sometimes it's in red font, sometimes it's in bold font, sometimes it's in italic, sometimes it's underlined, but for the residents and fellows, those are facts that seem to show up on test and tested again and again. So the first few slides are on the fundamentals. You have to remember that intraocular pressure is determined by three things. One, how quickly the aqueous is produced. Two, how hard it is for the aqueous to get out of the eye across the trabecular meshwork, and that's actually the point that's most important in determining IOP, and then also episcleral venous pressure, which is resistance a little bit further downstream from the trabecular meshwork. Remember the Goldman equation. This says that P naught, which is intraocular pressure, is determined by the rate of aqueous formation over the facility of outflow, which is the inverse of resistance, plus the episcleral venous pressure. So things that might show up on the test are, they'll ask you if you vary one of these factors, what will the effect be on intraocular pressure? So you can see from this equation that relatively small changes in the facility of outflow can have a very large effect on the intraocular pressure. Episcleral venous pressure, that's also a classic question, that it's like a one point to one point relationship in the acute situation. So, but even so, a relatively large change in episcleral venous pressure may not have as big of an effect on the intraocular pressure as a relatively small change in the outflow facility. Aqueous humor is produced at the ciliary processes. There are 80 of them. There is a double layer of epithelium there's non-pigmented and pigmented epithelium. The apices of those two cells are what is thought to be forming the blood-aqueous junction, or blood-aqueous barrier, rather. The aqueous is thought to actually be formed in the non-pigmented epithelium, which is the inner layer, and that's because there's a lot of mitochondria in the non-pigmented layer. So again, those are test questions they like to ask. The blood supply to the ciliary body comes from the major arterial circle of the iris. Again, just a fact that you need to remember. Aqueous humor formation, there's three ways that it's formed. Active transport or secretion. This accounts for the majority of aqueous production. This is pressure independent because you actually are using energy to create active transport. There's also ultrafiltration. This is a pressure dependent movement along a pressure gradient. And then there's simple diffusion where ions are just passing across the membrane. Aqueous humor, another test question, is they want to know what it's composed of. And relative to plasma, aqueous humor is high in hydrogen, chloride, ascorbate, and lactate, and it's relatively deficient in bicarbonate, protein, calcium, and glucose. There's other components. I do recall a test question on this. So you can have growth factors in there, carbonic anhydrase, lysozyme, CAMP, catecholamines, etc. And keep in mind that the composition of the aqueous humor does change as it flows through the eye because certain things are being taken away by the eye and certain things are being added. The rate of aqueous formation is 2.5 microliters per minute. That is important because the typical anterior chamber is 250 microliters, so you can actually change over the entire aqueous humor volume in about an hour. The rate of aqueous humor varies throughout the day. It decreases during sleep. This is why beta blockers at night are not as effective as a beta blocker administered in the morning. Aqueous humor also decreases with age, probably because there's less, blood flow to the area. But pressure doesn't necessarily increase in everyone because your outflow facility also changes. Aqueous formation can decrease with an eye injury or inflammation, so that's why we see low IOP with uveitis. Anesthetics can decrease it, and then obviously if you have carotid occlusive disease, that is the reason for lower eye pressure in an ischemic eye. Fluorophotometry is a test that actually measures the rate of aqueous formation. It's really just used for research studies, but you want to know a little bit about it because it is sometimes on the test. Basically, fluorescein is instilled in the eye, and then the rate that it disappears is measured. Trabecular outflow is the main way that aqueous gets out of the eye. So the pathway is that aqueous goes from the anterior chamber through the trabecular meshwork into Schlemm's canal and then out through scleral collector channels and finally into this episcleral venous plexus. This pathway is a little bit more important now because we have a lot of surgeries that actually target Schlemm's canal, and so the collector channels, there's a lot more interest in what's going on in the collector channels at this point because the surgeries don't always work for a very long time. So something obviously is happening downstream of Schlemm's canal. There are three trabecular meshwork zones. There's the uveal, corneoscleral, and juxtacanalicular. Just remember that the juxtacanalicular is the primary point of resistance to outflow. The trabecular meshwork is covered by a continuous endothelial layer, and the cells are phagocytic, and it does act as a one-way valve. So normally, if you do one of these newer surgeries, usually you see blood flowing back out, and you don't see that in the normal eye because of this one-way valve situation. Another important outflow pathway is the uveoscleral outflow pathway. This is the one that is thought to be increased by prostaglandin analog eye drops. Here, aqueous passes from the anterior chamber through ciliary body muscle into the superciliary and suprachoroidal spaces, and then it flows out along sclera or perforating nerves and vessels. This is a pressure-independent pathway. It's decreased by age and with meiotic drops, and then, as I mentioned, prostaglandins increase it, as well as cycloplegic drops also increase it, and adrenergic agonists, and then obviously cyclodialysis. If you create a cleft into the ciliary, in the superciliary space, you're going to have increased outflow. Episcleral venous pressure usually runs about 8 to 10 millimeters of mercury. As I mentioned before, in an acute situation, the IOP rises 1 millimeter of mercury for each 1 millimeter rise in the EVP, and that's because of the Goldman equation that we reviewed. EVP is relatively stable, although it can change with changes in your body position. So all those studies out of San Diego that showed that intraocular pressure seems to be higher at night when people are sleeping, it's thought that it's because people lay down, and so the EVP goes up, and therefore the pressure goes up. Okay, so intraocular pressure, the mean in the population is 16 plus or minus 3 millimeters mercury. That data actually comes out of a Northern European population, so in reality it might be a little bit different for the whole world. But what probably does hold for the whole world is that there's a non-Gaussian distribution of pressure with more pressure skewed towards the higher end of that 10 to 21 range that we all learn about. There are many factors that influence intraocular pressure. I'm going to let you go through the list on your own, but some simple things like Valsalva or breath holding. So a pressure may artificially be high if someone's nervous and holding their breath while you measure their pressure. There was also some stuff in the news a number of years ago about tight neckties being associated with high eye pressure, and then some diseases like thyroid disease can be associated with high pressures. Some factors also decrease intraocular pressure. Notably, aerobic exercise, probably only by like a millimeter or so, similarly with alcohol consumption. IOP varies throughout the day, so this is obviously something important to communicate to patients. It varies in a normal individual 2 to 6 millimeters mercury. If you're seeing variations of over 10 millimeters of mercury in a patient, you want to have a suspicion that maybe this patient is predisposed to developing glaucoma. And the other thing to remember is that the higher the intraocular pressure, the greater you're going to expect the fluctuation to be. An important equation for clinical measurement of intraocular pressure is the Imbert-Fick principle. This says that pressure equals force over area. This equation was, developed keeping in mind like this, ideal sphere that's dry, infinitely thin. The cornea and the eye are none of these things, so really, it doesn't hold 100%. The Goldman and Perkins applanation tonometer tips are the devices that the Imbert-Fick principle applies to. Here again is a big test question. I think it shows up almost every year. These instruments, the force necessary to flatten an area of the cornea of 3.06 millimeter diameter. So they'll ask you, they'll try to trip you up by saying 3.06 millimeters radius, 3.06 millimeters squared. Remember that it's 3.06 millimeters in diameter is the area that needs to be flattened to measure the force. The resistance to flattening is counterbalanced by the capillary attraction of the tear film to the tonometer head. Again, that's another fact that they like to test you on. And then it's relatively unaffected by ocular rigidity. These instruments are relatively unaffected by ocular rigidity because they displace so little fluid, so the displacement doesn't really raise the intraocular pressure. The Goldman applanator is most accurate with a central corneal thickness of 520. The average in the population is a little bit higher. It's actually 540. The Goldman applanator can give you falsely low pressures if the Meyers are very thin, so if you don't have enough fluorescein in the eye, if the cornea is edematous, if you have a contact lens in the eye, or if the cornea is thin. You can get falsely high measurements if you have too much fluorescein in the eye, giving you very wide Meyers, if there's a corneal scar, or if the cornea is thick. There are many different tonometers now on the market, and they all have their own unique attributes. The dynamic contour tonometer, which is pictured here, is non-applanating. So it doesn't actually push on the cornea. It has the shape of a cornea, and so it matches the cornea's shape, and somehow it is able to measure the pressure once the shapes are matched. This instrument is the best for measuring intraocular pressure in a post-LASIK eye. There's studies showing that pre-LASIK and post-LASIK IOP measurements are similar. So it doesn't seem to be affected at all by central corneal thickness, and it's least affected by biomechanical factors of the eye. However, it is going to be affected by corneal curvature issues. So this is not a good device for someone with a steep cone from keratoconus. Other instruments are the tonometer. I think tonopen is a trade name. There's other pen instruments. These work by a strain gauge that sends an electrical signal, which gives you the pressure. There's also pneumotonometers, which have a gas-filled chamber covered by a diaphragm. As the diaphragm touches the cornea, pressure in the gas chamber increases, and that's what gives you the pressure reading. These devices are very good for eyes that have corneal scars, because you can, get around the scar. They're also considered good for edema. They're also considered to be good for pediatric cases. This is the rebound tonometer. This shoots a little pinhead at the cornea, and how fast it comes back to the instrument somehow gets translated into the intraocular pressure. Its advantages are that you don't need to use anesthetic. So it's great for kids. There have been a number of studies lately that show that you should question very high pressures. You should always, if you get a high pressure with this instrument, you should try to measure the pressure with something else, because it can be off by 10 millimeters of mercury. But if you're in the normal range, it's probably accurate. Other methods to measure pressure, the Schiot's applinator. This one's not used very much anymore, but basically you have put a known weight on the device, and then you read off the linear scale up here. This is for the residents who probably haven't seen this. You read off the linear scale here, and then you go to a calibration table for the specific weight, and it tells you what the pressure is. There's some disadvantages of this because it does displace a significant volume. It really indents on the cornea, so it can displace a significant volume of aqueous humor. So this is going to be very affected by ocular rigidity variations. There's also the air puff, which measures the time necessary for a given force of air to flatten the cornea. And this is great in a situation where you don't want to pass germs around between patients, but it can have very variable readings and it can overestimate the pressure. So it's really best for screening situations. There's lots of errors in IOP measurement, especially for the applanation. If someone's squeezing their eyelids, if they're holding their breath, if the person measuring the pressure is pushing on the eye too much, et cetera, et cetera. A couple that you want to just be aware of that you might not think of is that marked corneal astigmatism can affect the pressure reading. And you always want to think about an inaccurately calibrated instrument. So everyone probably knows this, the ocular hypertension treatment study really brought this fact out that central corneal thickness does affect the intraocular pressure as measured by Goldman applanation and many of the other instruments because the cornea doesn't really follow the Imbert-Fick principle perfectly. But just remember that thicker corneas resist indentation, so the pressure tends to be higher than what is actually the pressure inside the eye. Steeper corneas also resist indentation. So if you have a keratoconic eye that's with very steep Ks, your IOP may be off. And then just always remember, since I work at the VA, this is a huge issue, infection control. So just remember you always have to sterilize the tips. And the AAO says you can do it with bleach, hydrogen peroxide, or alcohol. Okay, so we're going to move into genetics a little bit. Primary open-angle glaucoma, it does seem to have a hereditary component to it because family history is a risk factor for the disease. There's a 10% prevalence of open-angle glaucoma in patients who have siblings with open-angle glaucoma. Also, the lifetime risk of glaucoma in an elderly patient is 10 times higher if there's relatives with glaucoma than if there's no relatives with glaucoma. Another fact is that steroid responsiveness is inherited as an autosomal recessive trait. And then there's a lot of genes that are being found for glaucoma, but this is clearly not a one gene, one disease situation. There's probably many, many genes that all have to be triggered by the environment and coalesce to actually cause glaucoma in patients. That's for adult glaucoma, whereas for juvenile glaucoma, the tiger myocilin gene does seem to be a pretty strong correlation to actually, if you have this disease mutation, people do get glaucoma at a young age. There are 8 primary loci of adult onset glaucoma that have been identified. All are autosomally dominantly inherited. And the GLC1A is associated with mutations of the tiger gene. GLC1B and 1E are associated with normal tension glaucoma. It's thought that mutations render the nerve abnormally sensitive to normal pressures. And then the GLC1C and 1D are associated with high pressure glaucomas. With primary congenital glaucoma, again, there's a number of loci that have been identified. For testing purposes, you want to remember that GLC3A is associated with the cytochrome P50 gene. And if you have that, I think this gene mutation has been found in a lot of the Middle Eastern countries. And so there's very severe glaucoma if that mutation is found. And then GLC3C is associated with latent transforming growth factor binding protein. And these mutations do seem to account for about 3/4 of congenital glaucoma. And then with a number of different syndromes, there are also genes that are associated. I'm going to leave you just to memorize this list because I think the pediatrics lecture is also going over a lot of those associations. Okay, so we're going to move on to clinical assessment. A couple of facts. With gonioscopy, you have to put a gonio lens on the eye to actually see the angle because there's this critical angle at the tear-air interface of 46 degrees. Again, that's a testable fact. That doesn't allow you to see the angle unless you have a mirror on the eye that can overcome that 46 degrees. There are both direct and indirect lenses, or direct and indirect ways to view the angle. The direct view is with a Kepi or a Barkin lens, and this gives you an erect view. So basically what you're looking at is you're looking directly, you're seeing directly the angle that you are putting the light on. With the indirect, you get an inverted image, and you're actually looking in, you'll look at the superior mirror, but you're actually seeing the inferior angle. And they'd like to ask you to see if you really understand the difference between indirect ophthalmoscopy and gonioscopy. They'd like to ask you, are the images flipped? So just remember, if you're looking at 2 o'clock at a mirror at 2 o'clock, you're looking at the angle directly below it. So you're looking at 4 o'clock. You're not looking at 7 or 8 o'clock. There are different gonioscopy grading systems. There's the Schaefer, which is a little simpler. 0 is closed, grade 4 is open. There's the Spaeth, which is a little bit more detailed because it gives you, you describe what the insertion of the iris looks like, how wide the angle is the iris inserting in steeply, regularly, or kind of coming from below, which is called a queer insertion. You're describing the trabecular meshwork pigmentation and describing if there's PAS, neovascularization, or recession. So it really gives you a lot more information. So this angle on the Schaefer system would simply be grade 4. With the Spaeth system, this is D because the iris looks like it's inserted on the ciliary body. There's a 45-degree angle between the iris and the cornea. It's a regular insertion. There's 4+ pigmentation, and it does not look like there's any neovascularization or synechia in this angle. Another thing that you can see on gonioscopy is whether or not there's blood in Schlemm's canal. So I always found on the test that the pictures you're sort of always guessing, like, what are they trying, what am I supposed to see on this picture, because the pictures aren't always the best quality. But if you see a reddish tinge to the trabecular meshwork, you should assume that there's blood in Schlemm's canal, giving you that red tinge. So this happens when episcleral venous pressure exceeds intraocular pressure. So usually the test answer is either that there's been compression of the episcleral veins by the gonio lens that you're pushing on the eye. The eye could be hypotenuse. There could be a CC fistula. So that's something to remember, because that can threaten life and eye. Or there could be Sturge-Weber syndrome. All right, so the optic nerve is composed of neural and glial tissue, as well as extracellular matrix and blood vessels. So you just want to keep in mind that there is more than just nerve tissue there. Patients have 1.2 to 1.5 million axons as they begin adulthood. The cell bodies of the retinal ganglion cells sit in the ganglion cell layer of the retina. The optic nerve head, on average, is about 1.5 millimeters wide as your view at the slit lamp, but behind the eye it expands to 3 to 4 millimeters in width because of the myelin. There are 3 types of retinal ganglion cells. There are the magnocellular, which are large diameter axons and large receptive fields, and these are thought to detect motion. The parvocellular are the most abundant in the eye. These are small diameter and account for color vision. And then there's the coniocellular, which account for blue-yellow opponency. So this last type is the type that's being tested with the blue on yellow visual field test that we'll talk about in a few slides. But the idea here was, the magnocellular, because they have such large receptive fields, probably if some are damaged, others make up for it. So this may be why we don't detect visual field defects until there's a lot of damage. You have to have about 50% of the retinal ganglion cells damaged before you actually pick up a visual field defect. Whereas with the coniocellular, they're thought to be more sensitive. There's not very many of them, so if you start damaging them early in glaucoma, it was thought that you would start picking up blue on yellow defects on that visual field test, and you might actually be able to detect functional damage earlier on in the disease process. Okay, so some other facts about the optic nerve exam. Loss starts at the lamina corbosa. You can also see, or histologically, there's compaction of the laminar plates as nerve tissue is lost. And loss tends to occur at the superior and inferior poles. Asymmetry is a hallmark of glaucoma because only less than 1% of the normal population has asymmetry of greater than 0.2 cup to disc ratio. The isn't rule, which says that the inferior rim should be thicker than the superior rim, which is thicker than nasal than temporal. We teach that a lot, but you have to understand that it's not highly specific for glaucoma. And then another point to remember is that you want to assess disc size always. 5% of the population has a cup to disc ratio of 0.6 or up to up to 5% of the population has a cup to disc size of 0.6, and yet their nerve is still considered to be normal. And that's because their optic nerve head is larger. So the larger your optic nerve head, the larger your cup is going to be, even though it's not glaucomatous. And then another thing to look for on optic nerve exam carefully is for disc hemorrhages, because they're if you have recurrent disc hemorrhages in the same area, that indicates that that part of the nerve is sick, and usually there's visual field defects that develop in the corresponding area. Also, disc hemorrhages have been found to be more likely in normal tension glaucoma. Again, that's a test question that they like to ask. You also want to look for beta zone peripapillary atrophy, which is seen infratemporally on this nerve. That's a loss of the choriocapillaris and the retinal pigment epithelium. And the position of this atrophy usually correlates with the position of the visual field defect. Optic nerve imaging, the BCSC likes to emphasize that photographs are still very valuable, but obviously imaging is as well, because it provides an objective means of reproducible high-resolution images. It also provides a normal data, like a database of normals to compare against. And then probably the biggest benefit of it is that you can actually assess progression using serial analysis. This is just an image of a confocal scanning laser ophthalmoscopy. This, like a CT scan, takes slices through the nerve, and then it shows you the topography of the nerve, and then software will do an analysis to give you the likelihood of normal versus not normal, or the likelihood of progression. The scanning laser polarimeter, this detects changes in polarization. The retinal nerve fiber layer is birefringent because of the parallel structures of the microtubules, and so it reflects light back. The important thing here to remember is that the measurement here is a relative RNFL thickness. It's not an absolute. So whereas optical coherence tomography is actually giving you the actual thickness of the retinal nerve fiber layer, this instrument doesn't. And then, of course, there's optical coherence tomography, which you all know a lot about. I'm sure Retina went over this section. Just for glaucoma purposes, you always want to look at the quality score. Different instruments have different quality scores, but you want to make sure it's high. You want to look at these individual thumbnails that the different manufacturers give you. You want to look at, usually there's a little red line that delineates the retinal nerve fiber layer. You want to make sure that there's not big dropouts, that the computer didn't miss the retinal nerve fiber layer altogether. And then you want to look to see if the retinal nerve fiber layer shape of the individual patient follows the normative database. There's also now imaging of the macula. And the reason this may be beneficial is that a large proportion of macula thickness is composed of retinal nerve fiber layer and ganglion cell bodies, and the macula contains over half of the retinal ganglion cells. Different manufacturers measure different things. So some measure just the RNFL, some measure the ganglion cell and the ganglion cell complex, and some measure also the internal plexiform layer. So depending on what company, what they call the RNFL may actually be a few different layers. And at this point, there's a questionable benefit over just getting the RNFL layer that you get from this instrument, or the optic nerve head measurements. Okay, so visual fields measure differential light sensitivity, and there's a number of artifacts to be aware of that they like to test you on. They may give you an example of a lens rim, so you're going to have a lot of darkness, just around the edges here, and that's usually because a patient their head has fallen back a little bit from the machine, so they're seeing the edge of the lens in front of them. Refractive error will usually show up as just a diffuse depression, because if their vision is blurred when they're in the bowl, they're not going to see that little light that's being projected at them. An eyelid defect from ptosis is usually going to be just an upper defect with a normal nerve. Cloverleaf pattern, this is almost a cloverleaf pattern, but basically the tests usually start in the middle of these 4 quadrants. So the patient at the beginning is awake and alert and pressing the button, doing a great job, and as the test goes on, they get bored or they get tired and they stop pressing the button. So you'll sort of have that black area in a cloverleaf type of pattern. High false positives, this is the biggest reason why you would really throw out a visual field. High false positives mean that the patient is just hitting the button no matter what's happening. Every time they hear a noise, they hit the button. So that is truly a unreliable field. You can really throw that one out. High false negatives, sometimes just when someone has bad disease, they'll have high false negatives just because that's the nature of glaucoma. So they'll see one dim light, but then the next time they won't really see it, then they may see it again. Those you do want to count. You do want to actually look at ones with high false negatives, because again, it could be disease, not just an artifact. They'll definitely on your test show you an optic nerve and a group of visual fields, or vice versa. You just want to really be paying attention to, is this a right nerve, is this a left nerve, and then if you see the superior notch, you want to get the inferior visual field defect. There's a number of different types of visual field testing. There's standard automated perimetry, SAP for short, and this is testing for the threshold where a patient can just barely see the light. The test is actually looking for the dimmest light that the patient can see 50% of the time. And this is with a white light against a white background. SWAP, which stands for short wavelength automated perimetry, has a yellow background to suppress the red and green cones, and then is projecting a faint blue light. And like I said before, that's theoretically to detect glaucoma a little bit earlier. There's also FDT, which is frequently doubling frequency doubling thresholds. These are looking at contrast sensitivity, and then more objective tests are VEPs and ERGs, which are, I think, really mostly done for research purposes at this point. This is an example of what a patient will see with an FDT test. It's a low spatial frequency sinusoidal grading that undergoes like a rapid reversal of flickering, so that it actually ends up looking like there's double the amount of lines. And this is actually pretty easy for patients to detect. It's a much easier test. Patients usually like it better than the standard white on white. The company has developed tests that look a little bit more like the patterns that we're used to, but at this point this is still mostly used for screening. It's not been validated for testing progression. A few more things to know about for the test. So we talked about threshold tests. There are super threshold tests. So these are tests that are presenting lights that it would expect, anyone in the normal population would be able to see. So these are tests that you would use in a screening situation. And then the threshold tests used to be done by a bracketing system where you test here, the patient sees it, so then you go dimmer, the patient doesn't see it, so you go back up, the patient sees it and you go back down, and you're trying to find that, that point where the patient can see it only 50% of the time. And that takes a long time per eye. So probably a decade or two ago, mathematicians came up with these efficient threshold tests. And these are the ones that are considered the gold standard that we use in the clinic now. SITA stands for Swedish Interactive Threshold Algorithm. And basically, it can forecast what the patient, after a few points are done, it can forecast what the patient will probably see at the next point. So it can reduce the testing time by half. And SITA is what the Humphrey system uses. Tendency-oriented perimetry, or TOP, is what the Octopus system uses. All right, so now we're going to go into the open-angle glaucomas. Risk factors obviously are very important for glaucoma. Increasing pressure, increasing age, decreased CCT, black race, and family history. These are risk factors that have definitely been shown to be risk factors in the literature. The ones on the right-hand side here, the data is not so overwhelming that these are definite risk factors. I was going to go through each one of these risk factors and just review a few of the facts that you need to know for the test. One is prevalence. In people 40 and older, the prevalence of open-angle glaucoma is about 1 to 2%. When you get up into a group of people in their 80s, it jumps up to 11%, and that comes from the Baltimore Eye Study. Visual field defects are 7 times more likely to progress if you're over 60 years of age, and that comes from the CIGIT study. Conversion from ocular hypertension to primary open-angle glaucoma increases with each decade of age. And that's from the ocular hypertension study. And then in a Japanese population, glaucoma increases with age without an age-related IOP increase. And anyone who was at Grand Rounds the last week or two will remember that in Japan and Korea, low-tension glaucoma is the prevailing form of glaucoma. Race. Again, this data is mostly from the Baltimore Eye Study. Blacks and Hispanics have 3 to 4 times higher prevalence of glaucoma than whites. It's 4 times more common to be blind from glaucoma if you're black. And then also glaucoma tends to be diagnosed at a younger age and at a more advanced stage in black patients. In the Oates study, that study found that blacks were 59% more likely to develop glaucoma in a univariate analysis. But then when central corneal thickness and vertical cup to disc ratio were put into the equation, then they were no longer more likely to develop glaucoma. So central corneal thickness, no one knows exactly if the reason, so patients with low central corneal thickness do have higher rates of glaucoma, and they have worse glaucoma. It's not known if that's just a measurement issue, like are we just missing that their pressure was higher, or is there some kind of susceptibility because they have low central corneal thickness, so something else about their eye is actually making them more susceptible to glaucoma. And then family history, we sort of talked about this already, but the Baltimore Eye Study did show that the risk was 3 to 7 times higher if you had a sibling with glaucoma. So these are the other disorders that I said are sort of plus minus in terms of being risk factors for glaucoma. You can see that each one of them, myopia, diabetes, blood pressure, some major studies show that they are a risk factor, other studies show that they're not. So I think that the test could ask you about these in some way. And then retinal vein occlusions are associated with glaucoma. So is sleep apnea maybe, thyroid, migraines, Raynaud's, and low cerebral spinal fluid pressures have also been possibly associated with glaucoma. A word on prognosis. Most patients with glaucoma will retain useful vision their entire life. The greatest risk of going blind from glaucoma is if you present with very severe visual field loss. The Olmsted County in Minnesota has had a study going on for decades now. Their most recent publication from 2014 showed that the cumulative risk of blindness is actually lower now in the last decade or two compared to if you were diagnosed with glaucoma in 1960. So the numbers now, within 10 years, 7.4% of patients will be blind in one eye and 3.4% will be blind in both eyes. Within 20 years, those numbers go up a little bit, 13.5% in one eye and 4.3% in both eyes. Okay, so the next section, I'm going to just briefly go over the highlights of the major clinical trials in glaucoma. The Advanced Glaucoma Intervention Study, known as AGIS, was designed to determine which is better, laser trabeculoplasty, and not selective because that didn't exist at the time, so argon laser trabeculoplasty, or a trabeculectomy in patients who had advanced glaucoma and their pressures were still considered to be too high on medical therapy. The main outcomes were visual acuity and visual fields. So that was what the study was actually designed to look at. Because there was so much data collected in this study, there was, I think ages 15, there's a lot of different studies, and a lot of it's a sort of post hoc analysis. So you have to look a little bit skeptically at some of the conclusions. But what the study did was it took patients and randomized them either to a laser trabeculoplasty, and if that failed, a trabeculectomy. If that failed, another trabeculectomy, versus doing trabeculectomy, laser trabeculectomy. And the main study results was that there was no difference between treatments. They did find that if you had lower pressure, you had less progression on the visual field and on the optic nerve. And then over 6 years, patients with a pressure of less than 18 had near zero visual field loss. So this is where the concept of target pressures really came out of, because this study showed that if on every single visit your pressure was less than 18, you were much less likely to progress than if your pressure was all over the place. And then the last conclusion that was highly popularized, but that the study was actually not designed to answer, was the difference in these two randomization groups, whether for black patients and white patients. So it was found that black patients did better if they had laser before a trabeculectomy, versus whites did better with a trabeculectomy first. And these are just some graphs that you can look at on your own. One fact that comes up over and over in the glaucoma studies is that cataracts form at a much faster rate if you've had a trabeculectomy. So even if the trabeculectomy doesn't cure your glaucoma, it is going to give you a cataract if you don't have one already.
Is there a reason for that?
Probably just the change in aqueous humor dynamics. The lens is pretty sensitive. Okay, so the next study is a collaborative initial glaucoma treatment study. This one was designed to see if what was better for a first treatment for glaucoma, medications or trabeculectomy. And they took newly diagnosed open-angle glaucoma patients, and they randomized eyes. So one eye got medication and one eye got a trabeculectomy. And the unique thing about this study is that they had a individualized target pressure for every single patient. So it's actually kind of a complex equation, but every patient got their target pressure. And after 8 years, what they found in this study was that visual field loss was very similar between treatment groups. The IOP was slightly lower in the surgery group. The rate of cataract surgery was higher in the surgery group. Quality of life, so they did do quality of life questionnaires for these patients, and they found that by the end it was similar, but early on the patients who had surgery had a lot more complaints because they had irritation and other complaints about the surgery. And this study, the other thing that's very unique about it, and it's probably related to the fact that it has this individualized target pressure, which was pretty aggressive, is that there was a much lower rate of progression in this study than in other studies. So it sort of argues for getting a low, really aiming for a low pressure. And these are some graphs, again, from the study that you can go on over your own time, but I'm trying to get you guys out of here at a relatively reasonable hour. All right, so then the other study is the Early Manifest Glaucoma Trial, EMGT. This one was designed to compare the effect of immediate lowering of IOP to no treatment on the progression of newly diagnosed open-angle glaucoma. So this is a true control group. The newly diagnosed subjects were randomized either to getting ALT ALT plus betaxolol or no treatment. So you can see that this is from a while ago before some of the better drugs came out. And the results were that intraocular pressure was lowered by 25% in patients who got ALT and betaxolol. After 6 years, progression was less frequent in the treatment group versus the untreated group. And it occurred later. So you were having fewer patients with glaucoma getting worse, and the ones that were getting worse, if they got laser and betaxolol, were getting worse later. So it delayed progression. And then they saw particularly beneficial effects of treatment in certain groups. Actually, the treatment was good for all patients, rather. So whether you're young or old, whether you had high or low pressure glaucoma, whether you had pseudoexfoliation or not, everyone benefited from a lower pressure. And again, some charts from the graphs from the study for you to look at. So the EMGT study also published that there were some baseline factors that were predictive of progression: having a higher IOP, having pseudoexfoliation, having a worse visual field at baseline, and older age. They also reported that disc hemorrhage was a risk factor for progression, and then they also came up with this 10% of progression, or progression is reduced by 10% for each millimeter of mercury lower IOP for the group, not for an individual, but for the group. So the next group of patients is a glaucoma suspect. The BCSC keeps changing the definition of what a glaucoma suspect is, but the latest one is that it's a patient with an abnormal optic nerve, or someone who has a visual field abnormality, but their nerve still looks normal. All right, so the next study is the ocular hypertension treatment study. This was designed to determine whether topical eye drops are safe and effective in delaying or preventing glaucoma in patients with high eye pressure but no glaucomatous damage. They have normal nerves and normal visual fields. They took patients with intraocular pressures between 24 and 32 millimeters mercury and randomized them either to treatment of at least 20% lowering using medicines or no treatment. And the endpoint here is different than with other studies. Most studies usually use visual field progression as an endpoint. This one actually used a change in the optic nerve as an endpoint as well. Ocular hypertension treatment was found to be safe and effective in delaying or preventing glaucoma. Most patients required more than one medicine to actually maintain that goal of 20% lowering. So I think that's a very clinically relevant fact. When you start someone on a drug, you can tell them that it's very likely that they're going to need a second drug at some point in the next few years. So the main endpoint of the study was that after 5 years, the probability of developing glaucoma was cut in half if patients were on treatment. So untreated, it was about 10%, and treated, it was only about 4.5%. And then the other big finding out of the study was that low CCT was an independent risk factor for developing glaucoma. All right, and again, some graphs from the study for you to review. I think we already sort of talked about central corneal thickness. I'm going to skip that. The OATS is ongoing, and there was this, the first publication at 5 years, then there was another publication at 13 years. So what they did after the initial 5 years was to the patients who were in the observation group, they offered all those patients treatment. So then if the patients agreed to treatment, they followed everyone on treatment. And what they were trying to see was if there was a penalty for delaying treatment. And after 13 years, They found that 16% of the patients who were treated from day one versus 22% of the people who started treatment, 7 years later, progressed to glaucoma. Both the patients who were initially treated and the ones who were initially observed had similar Kaplan-Meier curves once treatment was initiated in the observation group. So the conclusion from the study is that it's safe to delay treatment in the low risk ocular hypertensives, because they may suffer a little bit of damage, but if you catch it early, you really will stabilize it. The patients who are high risk, they should probably be started, right away, not tell them, well, we can just wait until we, see a change. Okay, and then some words about normal tension glaucoma. Some highly testable facts are that the visual field defects tend to be more focal and closer to fixation. Again, the high prevalence in Japanese and Korean. People with low tension glaucoma also tend to have low central corneal thickness. And then, of course, you have to exclude other causes of normal. When you see someone with normal tension glaucoma, you gotta, you might have to get an MRI. You may have to look at their blood pressure. You may have to look for other reasons for the nerve damage. That said, normal tension glaucoma patients do have a higher rate of vasospastic disease, ischemic vascular disease, autoimmune diseases, coagulopathies, and disc hemorrhages. So the collaborative normal tension glaucoma study was designed because ophthalmology as a group wasn't really sure if lowering the pressure in people with normal pressure actually stopped or helped glaucoma. So this study also has sort of a unique design. They were aiming for a 30% IOP reduction, and you could do that with any method, drugs, laser, or surgery. And what they did was they identified these patients with normal tension glaucoma, and then they followed them. And once someone progressed, that's when they were randomized into the study. And like I said, once they were randomized, they could get however they could get the pressure down to 30% was allowed. The results were that they found that intraocular pressure indeed seemed to be part of the problem in normal tension glaucoma, because people who were treated, the visual field progression rate decreased from 35% to 12%. So pretty significant. The other conclusion is that for some patients, a small group of patients, no matter what you do, they get worse. And then the other conclusion is that a large group of patients with normal tension glaucoma are not going to progress very fast. So, of course, when you see them, you don't know that. But for a lot of them, nothing may happen for 5, 6, 7 years. Okay, and again, this study found that doing trabeculectomies caused cataracts. Now going into the different types of glaucoma. So pseudoexfoliation, this is caused by an abnormal basement membrane-like fibrillar material similar to amyloid. You can find it on the iris margin, that's where we see it most often, and on the anterior lens capsule. You also might find it on the corneal endothelium. It can look like KP. You can find it behind the iris. It's found in iris stroma and in blood vessels. That's why there can be leakage on a fluorescein angiogram of the iris. And then it's found everywhere in the body, not just in the eye. This is the typical kind of transillumination you see with pseudoexfoliation. It's peripupillary. Other findings, the angle can be narrow because the zonules are weakened and so the lens can move forward. The trabecular meshwork can be very heavily pigmented in these eyes. And then they can have a Sampo-Lessie line, which is just pigment deposited anterior to Schwalbe's line. The risk of complications with cataract surgery are higher, as you all know, because the pupil doesn't dilate well and because there can be phacogenesis from zonular weakness. So obviously there's a higher rate of vitreous loss and lens dislocation during surgery. There can also be a high rate of lens dislocation years after the surgery, which can lead to an UGG syndrome, which we'll talk about in a little bit. Pseudoexfoliation is strongly age-related, so it's rare to see it in individuals younger than 50. It's very common over age 70. The prevalence varies depending on country. In Scandinavian countries, Russia, it can be very high, and a very high rate of patients with pseudoexfoliation material will develop glaucoma if you follow them for 10 years. Some differences between pseudoexfoliation and primary open-angle glaucoma that they like to test on. Pseudoexfoliation can be highly asymmetric. So you can have one nerve that's totally normal and the other one that's like a 0.9 cup with a horrible visual field, whereas in primary open-angle glaucoma, the eyes are usually a little bit more similar. There's a lot more pigmentation of the trabecular meshwork in pseudoexfoliation. The pressures are much higher. It's not unusual to have pressures in the high 20s and 30s with pseudoexfoliation. The prognosis is worse. The cataract issue. Also, they can have more inflammation after cataract surgery. Fortunately, the results of trabeculectomy are similar between the two glaucomas. True exfoliation syndrome is extremely rare. If you know glass blowers, you might find it, and glaucoma is uncommon in that condition. Pigment dispersion syndrome and pigmentary glaucoma. Here you have pigment deposition on the trabecular meshwork. So again, on gonioscopy, you'll have a very dark trabecular meshwork. You can also see pigment deposition on the lens periphery, on the cornea, endothelium. That's called a Krukenberg spindle. And it tends to layer there because of the convection currents. You know, how the aqueous circulates in the anterior chamber. It goes up close to the iris because of the heat, and by the cornea is cooler, so it gets heavy and flows down, and then the endothelial cells actually phagocytose the endothelium, the pigment. A Krukenberg spindle is not necessary for the diagnosis, but you definitely should be looking for all of these signs in anyone who presents with glaucoma to rule out these secondary causes of glaucoma. Pigment dispersion, they also get iris transillumination defects, but they'll be in the mid-periphery as shown on the top picture here. The reason for this is that it's thought that the back of the iris is actually rubbing against the zonules, and that causes pigment to be released into the eye. There has also been shown on UBMs that the iris sort of bows backwards, and some people have advocated an iridotomy to prevent that reverse pupillary block, but I think studies show that there's actually not a huge benefit to doing an iridotomy. Again, like I said, the trabecular meshwork will be very dark. It's a very homogeneous darkening of the trabecular meshwork. There's also something called Zant-Meyer's line, which is the pigment that you see on the lens equator after dilation. Sometimes you can get confused with heme. This is just a picture to show you pseudoexfoliation versus pigment glaucoma transillumination defects. It's a very popular test question. So pigment dispersion, 15% will develop ocular hypertension or glaucoma. The typical patient is a white myopic male, and the thing to remember about that is if you want to start pilocarpine on these patients, you really need to do a good retinal examination because they're highly myopic. The pilocarpine may predispose them to retinal detachments. Pigment dispersion, the classic clinical scenario is that someone comes in, young guy in his 30s or 40s will come in after playing basketball, all the, shaking and jostling causes the pigment to disperse, the pressure goes up, they're complaining of seeing halos because the cornea is a little edematous from the high pressure and they have ocular pain. And the pressure can vary widely here because of that sort of sudden dump of pigment into the trabecular meshwork. Right, open angle glaucomas due to lens problems. Phacolytic glaucoma, this is leakage of altered lens protein through an intact capsule of a hypermature lens. So you can see this kind of wrinkling of the capsule because all the lens material inside is liquefying and not taking up all the volume of the capsule. The treatment here is to control the pressure and take out the lens. Once you take out the lens, the glaucoma will go away. There's prominent cell and flare in phacolytic glaucoma, but no KP. So this is a way to distinguish this from the phacoantigenic type. There's no keratotic precipitates. You can see a pseudohypopion, though. Okay, we already went over that. Lens particle glaucoma, this is the type of glaucoma you see after trauma or after cataract surgery where there's retained lens fragments. Again, the treatment is to take out the lens that's causing the problem. You can start with medications just to decrease the pressure so that the surgery is a little bit safer, and you can start steroids also to decrease the inflammation. Phacoantigenic, I think they'll talk about this at more depth in the pathology section, but this is a rare entity where a patient becomes sensitized to their own lens protein acutely after surgery or some kind of trauma. It's granulomatous inflammation. You can have a moderate AC reaction. You will see KP on the endothelium in this condition. You can also have a low-grade vitritis, synechia are common, and there can be some residual lens material in the anterior chamber. The histology, you'll see the epithelioid and multinucleated giant cells, and the treatment here is to treat with steroids and get the pressure down, and then remove the lens. Glaucoma, fortunately, glaucomatous optic nerve damage, fortunately, is not common here. Intraocular tumors can also cause glaucoma. There's a number of different mechanisms for the glaucoma. It can be because the tumor directly invades the anterior chamber angle. It can be because there's angle closure from rotation of the ciliary body or the lens diaphragm moving forward. There can be intraocular hemorrhage, there can be neovascularization, and then there can be deposition of tumor cells or inflammatory cells within the trabecular meshwork. The most common tumors to cause glaucoma in adults are listed here: uveal melanoma, metastatic carcinoma, lymphomas, and leukemia. And in children, they would be retinoblastoma, juvenile xanthogranuloma, and mesoepithelioma. Inflammation of the eye can cause a secondary open-angle glaucoma, thought to be either from edema of the trabecular meshwork, endothelial cell dysfunction, blockage of the meshwork by debris, prostaglandin-mediated breakdown of the blood-aqueous barrier might be occurring, Schlemm's canal can be blocked, and then obviously steroids can induce high intraocular pressure. These are the diseases that cause uveitis that are commonly associated with open-angle glaucoma, both herpes viruses, toxoplasmosis, juvenile idiopathic arthritis, pars planitis, and Fuchs heterochromic. And one fact to just keep in mind, you should always assume that elevated intraocular pressure is due to the uveitis because the inflammation is not adequately controlled by steroids before jumping to the conclusion that it's due to steroids. You always want to look to see is the inflammation being treated adequately in these particular types of uveitis. Okay, then there's glaucomatocyclitic crisis or Posner-Schlossman syndrome. This is characterized by recurrent bouts of very markedly high intraocular pressure and low-grade inflammation. The KP in this condition are small and very discrete on the endothelium and trabecular meshwork. The etiology is unknown at this time. It's thought that maybe it's due to herpes virus or autoimmune. Typically seen in middle-aged patients, unilateral. Glaucoma will occur if you get chronic recurrent bouts of this high eye pressure. Fuchs heterochromic iridocyclitis. In this condition, you'll see iris heterochromia. The affected eye usually is lighter in color. There's a low-grade anterior uveitis. Here you see small stellate KP, and the eye, despite the inflammation, is not red. Does not look inflamed on the conjunctiva. This is also associated with posterior subcapsular cataracts. Glaucoma occurs in about 15% of cases. The type of patient you'll see this in is either men or women of middle age. Another finding is fine blood vessels across the angle, and these can cause hyphemas during surgery. Like when you make an incision to take out the cataract, these blood vessels can bleed. There's no correlation between the amount of inflammation and the development of glaucoma. Steroids do not appear to be effective in this condition, and it's thought that maybe rubella is causative. Okay, so again, remembering that equation that we showed in the beginning, raised episcleral venous pressure can raise intraocular pressure and lead to glaucoma. When you see an eye pictured here, this patient actually has just idiopathic raised episcleral venous pressure, but you do need to rule out other causes of it, such as an AV fistula, an orbital varix, or Sturge-Weber syndrome. Also, venous dysfunction from a tumor or thyroid ophthalmopathy could cause an increase in this pressure. Superior vena cava syndrome, and then finally tight scleral buckles may cause this. You'll typically see very tortuous, dilated episcleral vessels. The pressure can be high, and you do want to do gonioscopy to look for blood in Schlemm's canal. The treatment is to evaluate for the serious things by getting an MRIA. It's difficult for medications to lower the pressure below the episcleral venous pressure. So if the pressure, if the patient starts with a pressure of 30, there's no way you're going to get it down to 8 with medication. It's because, there's a floor when the episcleral venous pressure is high. Laser trabeculoplasty is not effective in this condition. If you do have to move on to surgery, you have to be careful about ciliocoroidal effusions and suprachoroidal hemorrhages. Trauma can be associated with glaucoma due to hyphemas, angle recession, irradiodialysis, cyclodialysis, lens problems, intraocular foreign bodies, and chemical injuries from chemical damage. Traumatic or angle recession glaucoma, this is typically a unilateral glaucoma that occurs months to years after ocular trauma. The risk is highest in the first few years after the trauma, but it never goes down to 0, so that's why we tell patients to keep coming back. It's due to a tear between the longitudinal circular muscle fibers. The amount of angle recession is correlated to the risk for the glaucoma, so if there's just 1 clock hour recession, the risk is relatively low. If there's 6 clock hours of recession, the risk is going to be much higher. It is thought that the patients most likely to develop glaucoma after angle recession are people who were going to get glaucoma anyways, because there's a study showing that 50% of the fellow eyes develop glaucoma too. So the trauma probably is one of those environmental factors that triggers one of the many genes. The treatment is like with any other type of glaucoma. The one thing to keep in mind is that laser trabeculoplasty is less effective in angle recession glaucoma. Gonioscopy is absolutely necessary to differentiate angle recession from other types of glaucoma. You're going to see a very broad angle recess. The iris may give you some clues that something's going on. The scleral spur may be more prominent, and you might see synechia at the border of the recession. This is a slide that shows a normal versus a recessed eye. Does anyone know which one's the recessed eye? Yeah, the one on the right. So here's the ciliary body band here, and here it's much wider. And they do like to show histopathology. I'm going to leave this up to the pathology section to review with you. Cyclodialysis clefts occur when the ciliary body separates from its attachment on the scleral spur. And the first thing you're going to see is hypotony, and it can be a really, really low hypotony, pressure 0, 1, unmeasurable pressures even. And that's because basically all the aqueous humor goes into the cleft and into the suprachoroidal space. The closure of the cleft, sometimes this can happen spontaneously, and the patient can suddenly have tremendous pain because their pressure goes from 0 up to 30, 40, 50. Sometimes it needs to be closed surgically. And these are some images of different pathologies. So this would be, is this showing up? Yeah. So this is a cyclodialysis cleft. Here you can see the separation of the ciliary body from the sclera. Here's another cyclodialysis cleft. This may trick you up a little bit because the iris is touching over here. This is normal. Here's an irradiodialysis. There's a break in the iris, and then angle recession, which is probably the hardest to discern, but it's basically the iris should be up here, and it's sort of fallen back. Hyphemas frequently happen after trauma, and the red blood cells and other inflammatory debris can block up the trabecular meshwork, causing the high pressure. The larger the hyphema, the greater the risk of increased pressure and eventual glaucoma. The risk of glaucoma is 50% if there's a total hyphema, and the risk of glaucoma is also highest if there's recurrent hemorrhages, and that's because the pressure will spike up. You have to have particular caution with a hyphema in someone with sickle cell disease. The red blood cells can sickle in the aqueous humor because the stagnant aqueous humor, the pH will drop, and then the cells will sickle, and they'll have a harder time passing through the trabecular meshwork. Patients with sickle cell glaucoma have a much higher incidence of glaucoma following hyphema. Even small hyphemas can result in increased intraocular pressure. Their optic nerve heads are much more sensitive, so lower level pressure that you would tolerate in someone with a normal nerve, you may not want to tolerate in someone with sickle cell disease. In hyphemas, you want to avoid miotics in all patients because if they have a hyphema, they probably have angle recession, and if you give them a miotic, that's going to pull the iris root and it can cause more bleeding. You also want to avoid topical carbonic anhydrase inhibitors in patients with sickle cell disease because these medications can drop the pH and then they're more likely to sickle. It can also, if you use oral drugs, it can actually send them into a systemic crisis. You also, in sickle cell disease patients, want to avoid the alpha-1 agonists like brimonidine because they can lead to vasoconstriction, and like I said, their nerves can be a little bit more sensitive to vasoconstriction. Some rules of thumb, if pressure is higher than 50 for 3 to 5 days, you may want to intervene surgically. In someone with sickle cell disease, if it's higher than 25, you may want to intervene much sooner. The main risk of hyphema is corneal blood staining. You're not going to usually don't get corneal blood staining if the pressure is normal, but if you have a lot of blood in the AC plus the pressure is very high, that's where you're going to get blood staining. Some other things that blood in the eye can cause is after a vitreous hemorrhage, you can have hemoglobin-laden macrophages, which will look like red-tinged cells in the anterior chamber. And again, it can be hard for these to get through the trabecular meshwork, and that can cause a secondary glaucoma. Ghost cell glaucoma, these are degenerated red blood cells or ghost cells from a vitreous hemorrhage. They lose their intracellular hemoglobin, so you'd want to take a little AC tap to look for Heinz bodies. And these can cause high pressure because they're less pliable than regular red blood cells. This can happen even 1 to 3 months after a vitreous hemorrhage. You do have to have a disrupted hyaloid for these cells to get into the anterior chamber, and the eye usually is non-inflamed. Right. And then UGG syndrome or uveitis glaucoma hyphema syndrome. This is secondary to chronic chafing of an intraocular lens. Classically, it's due to a poorly designed or poorly placed anterior chamber intraocular lens. It can definitely happen with a sulcus lens, which is right behind the iris and can cause chafing. But there's now a lot of reports of this actually occurring with lenses that are in the bag. So if the bag complex starts, moving around, such as in a pseudoexfoliation patient, that can also cause UGG. The patients will get chronic inflammation, so they can have an iritis. So a patient who's pseudophakic and over 50, you should think about UGG syndrome because it's unusual for someone over 50 to have their first bout of uveitis. They can present with cystoid macular edema. They can have iris neovascularization. They can get recurrent hyphemas, and there are case reports of amaurosis fugax actually ending up being UGG syndrome because the sudden onset of a hyphema will prompt the complaint of, a transient loss of vision. And then you want to look for transillumination defects. A gonioscopy can be very helpful to make this diagnosis, and UBM is extremely helpful to make this diagnosis because it's going to help you see where the lens is behind the iris. The treatment, obviously, is to remove the offending lens. Schwartz syndrome, this is a glaucoma associated with regimatogenous retinal detachments. The intraocular pressure normalizes after RD repair, and it's thought that the photoreceptor outer segments specifically are responsible for the elevated intraocular pressure. One can also get a glaucoma after corneal transplantation. It's most common with not the first transplantation, but a second or a third. And there's many different reasons for it. You can have both open angle and angle closure types of glaucoma. And then finally, open-angle glaucoma can be due to drugs. Cycloplegic medications can increase intraocular pressure, although they rarely actually cause a glaucoma. Steroids, of course, can cause a glaucoma. 1/3 of patients respond with a increase in pressure, although for the majority of these patients it's not clinically significant. The reason IOP increases is because there's an actual change in the trabecular meshwork, and the resistance increases at the trabecular meshwork. Patients who have glaucoma, patients who have siblings with glaucoma, they're more at risk for steroid response. Also, children are at much higher risk for a steroid response, so very important not to let them go without follow-up. And then diabetics and myopic patients can also be at more risk for a steroid response. 4 to 6% of the population will respond with a pressure increase of more than 15 millimeters of mercury. The rest, usually you see just between 6 and 15 millimeters mercury increase. The most likely culprits are prednisolone, dexamethasone, and intravitreal steroids. With intravitreal injections, you can see a rise in pressure in about half of patients. 25% of those patients will need medical treatment, and fortunately only 1 to 2% will need filtration surgery. Okay. Do people want just to take a 30-second stretch break? No? Okay. So we'll move on to angle closure glaucomas. This is responsible for half of worldwide glaucoma. It's the leading cause of blindness in China. The international group actually came up with a new classification system shown on the bottom of this slide. So primary angle closure suspect is someone who has iridotrabecular contact over 180 degrees of the angle. A primary angle closure is having elevated pressure or synechia with this contact, and then primary angle closure glaucoma is having the above plus optic nerve damage. So angle closure with pupillary block, this is the most frequent cause of angle closure. The pupillary block tends to be greatest in the mid-dilated position, so that's why patients leave, they get dilated in the office, and then a couple of hours later, when their pupil has started to come down, the contact is greatest, and then the pressure builds up, and that's when they call the office saying that they're having problems. Or that's why, you know, in the movie theater, or when they get scared, the pupil gets a little dilated, and then the whole problem gets initiated. Angle closure can also happen without pupillary block. This is if there's something pushing from behind, like a sudden submacular hemorrhage or a tumor, or it can be if the iris is being pulled due to synechia. Primary angle closure, the risk factors are having a small eye. So Inuits, Eskimos are at greatest risk because they just over evolution have developed smaller anterior segments to protect themselves from the cold up in the North Pole. East Asians have the next highest rate, and then whites and Africans have a much lower rate. So as I said, having a small anterior segment, having an anterior chamber depth of less than 2.5 millimeters is probably the strongest risk factor for having an acute angle closure attack. Age over 40 because the lens gets fatter, so that's shrinking the anterior chamber depth. Women tend to have smaller anterior chambers with the same size lens. Family history, refraction. Hyperopes tend to have smaller anterior segments, although myopes can as well. And then this last fact is just from the theory that Harry Quigley put out about why angle closure happens. It's actually a dynamic process. So most eyes, when the iris dilates, the iris actually loses volume. But it's thought that eyes that end up having an acute angle closure attack aren't able to lose that volume. So that's why they end up with the attack. These are the classic pictures of an acute angle closure eye. Patients present with high eye pressure, iris bombé. The pupil will be mid-dilated as you see in this picture, and you can see that the cornea is cloudy from edema. Blood vessels will be congested over the entire surface of the eye. The anterior chamber will be shallow, and there will be sullen flare. After the attack, you'll see the glaucoma flecken, which is the degenerated lens epithelial cells, those white spots on the lens on the lower picture. The iris will be atrophic. stick, and it'll still be in that mid-dilated position, because if the patient presented with a pressure of 60 or 70, the iris became ischemic, and so the muscle is damaged. And they can frequently have synechia. The untreated fellow eye has a very high chance, 40–80%, of having an attack over the next 5 to 10 years. So it's extremely important that both eyes get an iridotomy. And then after an attack is broken, the eye that had the attack can have a very low intraocular pressure for several weeks because of ischemic damage to the ciliary body. Patients can present with subacute attacks. They may tell you that they're having some blurred vision, some mild headache. You want to do gonioscopy on those patients. And then there's also chronic angle closure. This is a major cause of angle closure in Asia. It's also more common in Black patients. They say that it's creeping because the angle, you'll form synechia contiguously around the angle. An LPI won't stop the synechia from forming, but it will eliminate any pupillary block that might be contributing to the problem. Okay, plateau iris. This is a condition in which the ciliary processes are anteriorly positioned. So you can see on the UBM here, you see the normal, and on this slide, the ciliary processes are a little bit turned in, and you have this plateau configuration of the iris. The AC is typically deep, and the iris plane is flat, whereas in primary angle closure that leads to pupillary block, the iris is actually going to be vaulted upwards. These patients are still prone to angle closure after an iridotomy because the iris is so close to the trabecular meshwork there. These patients frequently can have discomfort after dilation. They tend to be female and younger. They're not hyperopic like the primary angle closure patients. The long-term treatment is meiotic therapy or iridoplasty, and we'll go over that in the last section. And then they should all get iridotomy to remove a component of pupillary block. And the iridotomy sometimes can be diagnostic. You have someone with narrow angles, you do the iridotomy, you gonioscope them again after the iridotomy, and their angle looks exactly the same. You should be suspicious that they may have plateau iris, and they should be sent for a UBM. Phacomorphic glaucoma, the clues to this is a patient you've been seeing for years. They always had open angles, and now they come in with, asymmetric gonioscopy, asymmetric cataract. Basically, their lens has just grown and narrowed the angle. So you're going to do either cataract surgery right away, or safer to do iridotomy and then cataract surgery. Ectopia lentis, this again has to be treated with cataract surgery. It's recommended to do 2 iridotomies 180 degrees apart. Since the lens can be mobile in the eye, it could shift over and close off 1 iridotomy. So having 2 is a little bit of insurance. This can be from trauma, from Marfan syndrome, homocystinuria, microspherophakia, Weil-Marchesani syndrome, or pseudoexfoliation. And then finally, aphakia, you can still get pupillary block even if there's no lens in the eye. What happens is if you have an intact hyaloid face, the vitreous can bulge through the pupil and block all flow of aqueous. So again, in this case, you want multiple LPIs because it's thought that things can get loculated behind the iris. So having multiple LPIs is insurance against a angle closure attack. Neovascular glaucoma is a angle closure type of glaucoma. Here you get a fibrovascular membrane which contracts, and then it causes synechiae. The synechiae typically end at Schwalbe's line. Neovascularization of the angle can occur before neovascularization of the iris. So if you have a diabetic, someone with a CRVO who suddenly has much higher pressure than you remember them having, you should do gonioscopy, not just look at the iris. And everybody wants to treat the the high eye pressure right away, but you really do need to do PRP on these patients because we need to treat the cause of the problem. ICE syndrome, again, cornea section will probably review this in a lot of detail. This is a syndrome where you have abnormal endothelium that can look like beaten bronze. It can cause iris atrophy, a secondary angle closure glaucoma, and corneal edema. It's typically unilateral in women in their 20s to 50s. The PAS in this syndrome are different than what you see in neovascular glaucoma. Here the PAS extend beyond Schwalbe's line because there's the endothelium is abnormal, so it's not causing a block for the, it's not preventing the PAS from going further than where they normally would go. And just a test question, the pressure doesn't necessarily correlate with how much PAS you have. Glaucoma does happen in about half of ICE patients. It's particularly severe in essential iris atrophy and iris nevus or Cogan-Reese syndromes. The treatment is medical. If you do have to do surgery, you want to do a tube. The abnormal endothelium can grow over a trabeculectomy that's made, so that's not going to happen with a tube. So just a word about PAS. We kind of mentioned them in passing, but in a gonioscopy picture, the pattern of the PAS can help you determine what the disease is. So in uveitis, PAS tend to form in the inferior angle. They'll be non-uniform in height and shape. In ICE syndrome, like I mentioned, they can go anterior to Schwalbe's line. In neovascular glaucoma, they'll end at Schwalbe's line. And in chronic angle closure, they tend to be circumferential and creeping. Okay, aqueous misdirection. This is a glaucoma that typically follows ocular surgery, rarely can even follow a laser iridotomy. It typically occurs in eyes that are predisposed to angle closure. Clinically, the anterior chamber will be shallow both centrally and peripherally because you have aqueous pushing things from behind. It can happen in aphakic and pseudophakic eyes. The pressure can early on won't be that high, but later on it can be extremely high. It's thought that the ciliary body rotates forward and that aqueous is misdirected into the vitreous cavity. The key things here are avoid miotics because it will worsen the situation. The first line treatment is cycloplegics to pull the ciliary body and the lens and everything back. Many can be controlled medically, but some will have to go on to surgery. A newer theory for aqueous misdirection is that this occurs typically in a small eye. The choroid expands, and somehow that decreases the conductivity of vitreous fluid, and it just sets up this cycle where the pressure goes up. When you do surgery for aqueous misdirection, you have to really disrupt the hyaloid phase. If a retina surgeon goes in and just does a core vitrectomy, it will not solve the problem. The anterior hyaloid phase has to be removed. Epithelial fibrous ingrowth is another cause of angle closure glaucoma. Epithelium can grow through a wound. So the biggest risk factor is a wound that was poorly closed. The epithelium can grow in pearls, cysts, and sheets within the eye. The picture on the top shows an eye that has had argon laser done to the iris to help diagnose the epithelial ingrowth. The epithelium in the eye will turn white when you treat it with argon laser. And this, unfortunately, usually requires quite radical surgery. And in terms of glaucoma, you should do a tube, not a trabeculectomy, again, because the epithelium can grow over your trabeculectomy site. Nanophthalmos, this is an eye that's small but with a normal shape. They typically are very high hyperopes with very low axial lengths and a relatively normal lens. So pupillary block can be the cause of glaucoma, as well as a uveal effusion pushing things forward. These eyes have very thick sclera, which can impede vortex vein drainage, so that's why they can get suprachoroidal effusions. The management is typically, you first start off with weak miotics. You can use a cycloplegic if there's no angle crowding. You want to try to do an iridotomy. You can try to do iridoplasty. And if you have to do surgery, you want to do prophylactic sclerotomies. Patients with retinopathy of prematurity can develop a secondary angle closure. Basically, retrolental tissue contracts, and that shallows the anterior chamber and allows synechia to form. This typically occurs around 3 to 6 months of age, although it can also happen later. All right, and the last angle closure, glaucoma is drug-induced. There are many case reports of topiramate and other sulfa-based drugs like Diamox causing this. Patients will present with an acute myopic shift, so they can go from plano to minus 8. And it's because they develop these ciliocoroidal effusions shown in the UBM here, which basically allows the zonules to let the lens move forward. The treatment is to stop the offending drug and to treat with cycloplegics. Okay, so the next section is on on pediatric glaucomas. These are due to an angle dysgenesis, so the angle has not developed normally. It's primary in about 2/3 of patients. Really remember 2/3. 2/3 are diagnosed by 6 months, 2/3 are in males, and 2/3 are bilateral. Most are sporadic or autosomal recessive. We went over these genes already. One point, though, is that all patients with pediatric glaucoma should be evaluated by a geneticist. All right, so the classic triad in primary congenital glaucoma is epiphora, photophobia, and blepharospasm. And what you'll find is the Hobbs-stria, which can be horizontally oriented or circumferentially oriented. Remember, vertical stria are usually from forceps trauma. Patients will present with corneal edema, and the later they're diagnosed, the more likely they are to have corneal edema. The corneal diameter can typically be greater than 12 millimeters, which is abnormal for an infant. The iris typically has a high flat insertion, and peripherally the iris can look hypoplastic. Medications can be initiated until surgery is performed, but surgery really is the first line treatment. It should be done very quickly. You do want to avoid alpha agonists in children less than 2 years of age because it can cross the blood-brain barrier. It's been associated with hypotension, apnea, so you really have to be careful about that. You also want to be careful using beta blockers in small children for obvious reasons. The first line treatment, as I said, was surgery. If the cornea is clear, you can do goniotomy, which you enter through the cornea and make an incision internally. If the cornea is cloudy, then you have to use an external approach, which is called trabeculotomy, and tubes and trabs can also be used in children. The diagnosis is worst for children who are diagnosed at birth, probably because their angle is so poorly developed that they're born with corneal edema and high pressures, or if they're diagnosed after 2 years of age. And the reason for that is that it's going to be more insidious, and they probably have a lot of damage by the time they're diagnosed. All right, juvenile open-angle glaucoma. This is glaucoma diagnosed in individuals from age 4 to 30. This is a high-pressure glaucoma. They have a normal angle. Frequently, it's autosomal dominant. Many of them have a progressive myopia. The myopia is, in this age group, their axial length is not increasing under pressure, so the myopia is from for other reasons. While you can treat many of these patients with medications, many of them will end up needing surgery. And angle surgery does work, even in the 20-year-olds. Many syndromes of the eye are associated with glaucoma, which makes sense. If there was a problem in development with one part of the eye, there can be a problem with development of the angle. Axenfeld-Rieger syndrome. This is a bilateral disorder that's inherited in an autosomal dominant fashion. Half the time it is associated with glaucoma. There's problems with development from the neural crest. What you'll typically see is the posterior embryotoxin, which is very obvious in the picture on the top here, extending very far centrally in this eye. They'll also get iris hypoplasia. They can get holes in the iris. They can get correctopia, where the pupil is displaced. And then systemically, you'll see periumbilical skin redundancy, pituitary abnormalities, hypospadias, and defects of the teeth and facial bones. Peters anomaly is, again, a problem with development of the posterior cornea. Patients can get adhesions of the iris to the cornea. This is seen bilaterally in most cases. Again, about half are associated with glaucoma, and they can have other systemic problems in the heart, the GU system, musculoskeletal, ear, palate, and spine. This is typically sporadic. Aniridia is another disease where about half of patients develop glaucoma. They can have two types of glaucoma. They can have open angle or an angle closure glaucoma here. The open angle usually happens in the first few years of life because of problems with development of the drainage system. The angle closure usually happens a little bit later, and that's because that little rudimentary stub of iris can actually rotate forward and cause angle closure. This is associated with the PAX6 gene. Remember that they also get foveal aplasia, which can lead to nystagmus, and you also see limbal stem cell deficiency in these patients. And then Sturge-Weber syndrome, again, is associated with glaucoma. 30 to 70% of patients will get it. It's more likely if the upper eyelid is involved. And again, you can have this present either early in life because of a congenital angle abnormality or later due to elevated episcleral venous pressure. And then neurofibromatosis 1, again, another condition where upper eyelid involvement portends a more likely presence of glaucoma. This is autosomal dominant. They present with ectropion uveae, Lisch nodules, optic nerve gliomas, cafe au lait spots, inguinal and axial freckling, and neurofibromas. And then the last disease in pediatric glaucoma is aphakic glaucoma. 15 to 50% will develop glaucoma after congenital cataract removal. It's not completely understood why. Usually the glaucoma will be within 3 years of the surgery, but the risk never goes down to zero, so they need follow-up throughout life. Okay, now we'll review the medications that are used to treat glaucoma. Prostaglandin analogs, the common side effects that everyone's familiar with is darkening of the iris, darkening of the periocular skin, hyperemia, and the changes in the lashes. Patients can also get hair growth around the eyes and the upper cheek. And then most recently reported they can get a lipoatrophy where the fat atrophies and they can get a sunken in appearance to their eyes, which can make it very difficult to measure intraocular pressure. Some lesser seen side effects of these drugs are exacerbations of herpes simplex if they are predisposed. It can exacerbate uveitis and cystoid macular edema. Okay, beta adrenergic antagonists. There are three types, selective, non-selective, and the intrinsic those with intrinsic sympathomimetic activity. The selective are selective for the beta-1 receptor. So these are safer if someone has a pulmonary condition. And the only drug in this class is betaxolol. The non-selective act both on beta-1 and beta-2 receptors, and there's a much greater risk of exacerbating COPD or asthma. The ones with the ISA activity, there's one in that class, cartiolol. And this, the benefits of this class is that there's less effect on nocturnal pulse and blood pressure and less effect on plasma lipids. But it also has an intermediate effect on intraocular pressure. So the best at lowering intraocular pressure are the non-selective, then the ISA, and then the selective. Lots of side effects from beta blockers. Bronchospasm and bradycardia are the most serious, as well as increased heart block. The one that they, I think, like to test on frequently is the decreased, it can mask the symptoms of hypoglycemia, so you have to be careful with diabetics. You can also, these are lesser known, again, that they like to test on. You can get a exacerbation of hyperthyroid syndrome symptoms if you suddenly stop a beta blocker in a patient with hyperthyroidism. Myasthenia gravis can be aggravated, and HDL can be affected. I don't know if they still test on this, but basically non-selective adrenergic agonists are not that effective in combination with beta blockers. So miotics, there's two classes again, the direct and the indirect. The direct are just like acetylcholine. They directly act on the receptor. These are pilocarpine and carbachol. Carbachol has two little asterisks on it because it actually has properties of both direct and indirect. The indirect anticholinesterases, these basically they inhibit the enzyme that breaks down acetylcholine, so it sort of indirectly increases the amount of acetylcholine in the junction. And this is ecothiopate and again carbachol. The way these drugs work is they contract the longitudinal ciliary muscle, which then pulls on the scleral spur, which then tightens the trabecular meshwork, which allows increased outflow. There's also some evidence that they might decrease uveoscleral outflow, so not the best drug to use in combination with a prostaglandin analog. Lots of side effects of these medications. They obviously cause pupil constriction because they pull on the muscles. They affect the lens position. They can increase the risk of retinal detachment. They cause myopia and a brow ache. There can be paradoxical angle closure, so you have to be careful in prescribing this to people with narrow angles. Punctal stenosis can occur, as well as pseudopemphigoid. The blood aqueous barrier can be disrupted, so there can be more flare after surgery. There can be increased bleeding during surgery, and you can see a fibrinous irritative cyclitis if they've been on it for a long time. And then ecothiopate causes cataracts in adults, and in children it causes these pigment cysts that you see in the picture here. And then probably the most important side effect of the indirect acting ones is that you should not use it. You have to stop it at least 6 to 8 weeks before you take someone to surgery if you're going to use a depolarizing anesthetic agent, such as succinylcholine, because they may not be able to move after surgery because the two drugs interact. Okay, so carbonic anhydrase inhibitors, there are systemic and topical forms. The systemic forms have many side effects. The most common are the paresthesias and decreased energy, anorexia, weight loss. The most serious are the kidney stones, the sulfa cross-reactivity, which could lead to a Stevens-Johnson's episode, aplastic anemia, and hypokalemia. Adrenergic agonists, again, there are non-selective and selective forms. The most commonly used are obviously the selective ones. In the non-selective, they are not used very much anymore because there are a lot of side effects. Blepharoconjunctivitis occurs in 20%. Cystoid macular edema is very common in pseudophakic patients. And then the most unique side effect are these adrenochrome deposits pictured in the photo. They can also get tachycardia and arrhythmias. They can also get eyelid retraction and vasoconstriction. So the selective are the ones that we commonly use in clinic. The main side effect are allergies, more so with aproclonidine than brimonidine. The brimonidine with the newer formulations, there's a little bit less allergy than there used to be. Rarely, especially in elderly patients, you'll see dry mouth and lethargy. And then, as I mentioned before, do not use this in infants because of all the serious side effects you can see, such as somnolence, hypotension, seizure, apnea. Okay, and then there are the hyperosmotics. Again, these medications can have some serious side effects. They can cause an acute congestive heart failure, MI, and there's reports of subdural and subarachnoid hemorrhages. And obviously, you don't want to use these in people in renal failure because they won't be able to clear the medication. There's medication, basically almost all the medications you want to use sparingly and avoid in pregnancy. Carbonic anhydrase inhibitors have been found to be teratogenic, so definitely need to be avoided in pregnancy. Prostaglandin analogs theoretically could cause uterine contractility, so that's why they're avoided. Beta blockers are used in pregnant women and can be used during pregnancy, but they should be avoided during breastfeeding because they are concentrated in breast milk. And then brimonidine also can be used during pregnancy, but are avoided in nursing mothers. Okay, so the last section is on surgery. The glaucoma laser trial is the only, the glaucoma laser trial was developed with the goal of seeing what's better, ALT or medication as an initial therapy. And they found that more eyes were controlled with laser than with medication. The medication at the time was timolol. There was no difference between groups in terms of visual field or visual acuity. But at 2 years, less than half of the patients still had a pressure controlled after laser. So the effect of laser wears off over time. The conclusions from the study were basically that it could be considered as primary therapy. We do use it as primary therapy for patients. Even now when we have better medications than they had when they designed the study. So like I said, the success rate decreases over time. Only half of patients maintain a lower eye pressure after 3 to 5 years of follow-up, and after 10 years, only a third do. Laser trabeculoplasty is less effective in aphakic patients, pseudophakic patients. When you do see an effect, you should expect it to be equal to one drug, so about 20 to 25% if it's used as first line. If you're using it as a second or third line treatment, you'll see a smaller drop. And then there's a similar effect between argon laser trabeculoplasty and selective laser trabeculoplasty. There are many contraindications to doing trabeculoplasty. If you have an inflamed eye, you don't want to use it because it can increase inflammation. In ice syndrome and neovascular glaucoma, it's not going to help because the angle is actually not open. Also with synechiae, there's going to be no benefit. Developmental glaucomas are going to see no benefit. In angle recession, you can try it, although success is at a lower rate than in primary open-angle glaucoma. And if it has no effect in one eye, it shouldn't be done in the second eye. Complications, 20% of patients in the glaucoma laser treatment trial had an IOP spike. The rate is decreased now that we use prophylactic aproclonidine. With argon laser trabeculoplasty, the risk of a spike is much smaller if you only treat half the eye. So that's why the standard of care was usually to treat half the eye with ALT, and then you treat another half. With SLT, we just go ahead and treat 360 degrees because the rate of spikes is pretty low. You can get a low-grade iritis, rarely a hyphema. A synechiae can form more after ALT than after SLT. And then the latest complication with SLT has been these reports of corneal edema and a hyperopic shift, similar to what you see with the sands of the Sahara after LASIK surgery. The differences between SLT and ALT. In ALT, you can customize things. So you can change the spot size. You usually want to use 50 microns. You can change the energy. And in SLT, the spot size is fixed. You can't change it. You can change the energy a little bit, although the energy is much less. And the benefit of SLT is that you're basically just using a lot less energy and there's no thermal damage. Laser iridotomy, this is a procedure done when you see pupillary block. You don't want to do it in patients that have flat chambers, corneal edema. If there's already 360 degrees of PAS, there's no point in doing it because really you're trying to prevent an acute angle closure attack and you're trying to prevent synechiae from forming. And you shouldn't do it if you see neovascularization. It can be done with a variety of different lasers, and there's many different settings. The complications that are normally seen are a pressure spike, hyphemas, and then postoperatively patients can complain of streaks of light, especially when they're driving at night from headlights. The iridotomy classically was placed superiorly. Now there's a couple of studies, 2 prospective studies that indicate that it might be better to place the iridotomy temporally. There was one study that actually randomized eyes. One eye got a temporal, one got a superior, and there was the fewer complaints with the temporal iridotomies. Laser iridoplasty, here's what it looks like. These are some pretty aggressive burns. But basically, you want to do this if in an eye with a very narrow angle that's already had an iridotomy, but they still look like they're, at high risk for synechiae forming, or in an eye with plateau iris, you would do this. The idea is to do a slow a slow, low burn to basically contract the iris and pull it out of the angle to create more space. Cyclodestruction can be done with a cyclocryo, or it can be done with a laser. Classically, the transscleral was reserved for eyes with poor visual potential or even blind eyes that were painful for high pressure, or a patient who couldn't go to the OR for surgery. The newer type, where it's done through an endoscopic probe, is done on patients with actually very good vision. It's done in conjunction with cataract surgery. So any level of vision is fine. Complications of a cyclodestruction, especially with the transscleral in like very sick eyes, there's a very high rate of loss of vision, a high rate of hypotony. There are reports of sympathetic ophthalmia. And then this is an it does induce inflammation, so that has to be watched. And obviously you can get cystoid macular edema if you're doing an endoscopic procedure. There's also reports of retinal detachments. Incisional surgery is indicated when there is progression on the visual field or even on the nerve, or when pressure is judged to be too high for the disease state and they're on all the medications that they can tolerate. Relative contraindications are, you don't want to operate on a blind eye. For a trabeculectomy, if there's active neovascularization, there's a very high chance that the surgery will fail. If there's active iritis, that will also increase failure rates. If there's a lot of conjunctival scarring, that's not good for a trabeculectomy, nor is thin problematic sclera. The success rate is lower in younger eyes and in black eyes. Antifibrotic agents have increased the success of a glaucoma surgery, particularly trabeculectomy, but it's also increased complications. You have to be careful in young myopic patients because their sclera is very pliable, so if their pressure goes too low, they're at great risk for hypotony maculopathy. There's two different antifibrotics that are used. There's 5-FU, which interferes with DNA synthesis. It's highly alkaline and it can cause epithelial defects. And then there's mitomycin C, which actually cross-links DNA, and that can be applied on a pledget or by injection. So a few things about trabeculectomies. There's obviously a risk of leakage, which can lead to blebitis and then endophthalmitis. There's definitely studies that show that prophylactic antibiotics are not a good idea. They select for resistant bacteria, and then when the patient gets the infection, there's nothing that there's no antibiotics, or you're very limited in the antibiotics that you can use to treat the endophthalmitis. After a trabeculectomy, one wants to look for an incision leak. Those can actually lead to early failure of the surgery. You want to look for hypotony, shallow or flat anterior chambers, which are not good for the cornea, and then for choroidals. Late complications, blebitis, the risk, there's a risk of about 1.3% every year. For superior bleb, the rate for inferior blebs is very high, and inferior blebs are not recommended. Endophthalmitis can occur. Hypotony maculopathy can occur late, as can bleb failure. Patients can have a bleb that overhangs onto the cornea, which can be irritating. They can develop ptosis, and they can have eyelid retraction. The risk factors for bleb-related endophthalmitis are blepharitis, conjunctivitis, trauma, nasolacrimal duct obstructions, contact lens use. We really dissuade patients from using contact lenses after a trab, a chronic bleb leak, and then being male, young, or having the inferiorly located trabeculectomy. Surgery, cataracts and trabeculectomy can be combined. However, trabeculectomy success is lower when done in conjunction with the cataract. The cataract extraction is very inflammatory, so that's bad for the trabeculectomy. However, if someone needs a cataract surgery and it's not thought that the pressure will go down adequately with cataract alone, then a trabeculectomy is indicated. There's a few studies that have shown that cataract surgery does actually lower intraocular pressure. The best evidence probably comes from the ocular hypertensive treatment study that showed that pressure does go down, although the pressure drop decreases over time. It showed that the IOP lowering is equal to about what you would get from one eye drop. And the patients that get the largest drop in pressure are the ones who start off with the highest pressures. And obviously, and so in OATS, that's in open angles. There's also lots of evidence, especially out of Asia, that pressure does go down after cataract extraction in eyes with angle closure. So just a few words about tube shunts. These are indicated when a trabeculectomy has failed, if there's active uveitis or a neovascularization, if there isn't a lot of conjunctiva near the limbus, tubes can be used. Aphakia, probably mostly because a lot of aphakic eyes have conjunctival damage already. And then somebody who really, has to wear a contact lens after surgery. The complications are similar to, you can see all the complications that you see with a trab, with a tube, but unique to a tube is diplopia. Corneal decompensation is seen at a much higher rate with tubes, and then erosion of the conjunctiva over the tube. There's a few studies that have looked at tube shunts. There's the trabeculectomy versus tube shunt study. This study compared eyes receiving a Barvelt to a trabeculectomy. They had a very particular definition of success, and they reported that Barvelts, there's a higher success rate with Barvelts than with trabeculectomies. And this was done, all the eyes in the study had already had some kind of intraocular surgery, mainly cataract surgery. At the end of the study, both trabs and tube eyes were on a similar number of medications, and they had a similar pressure, but the trabs had to go back for additional surgery, so that's why they failed at a higher rate, because there was something else that they needed to have done, whereas the tubes, once they had their one surgery, that was it. There's also, in the last 5 years, studies have come out comparing the Ahmed to the Barvelt. Both studies have similar findings. The Barvelt, gets the pressure down a couple points lower than an Ahmed on average, with usually about one medication less than an Ahmed does, but it looks like the Barvelts have more complications. And then the last slide, there are a number of new surgeries in glaucoma. They basically all shunt aqueous either to Schlemm's canal or to the suprachoroidal space, so they're enhancing the natural outflow pathways. They mostly all require a gonioscopic view of the angle, because it's all being done through a cataract incision, and they don't lower the pressure as low as a trabeculectomy can, so they're really indicated for early, maybe for moderate glaucoma, but definitely more for the early glaucomas. They're frequently done in combination with cataract surgery, and their most frequent complication to date seems to be hyphemas, because of you're letting the blood come backwards out of Schlemm's canal, because you're now creating a pathway.